welcome to this low flow project on behalf of both myself and GE Healthcare. My name is Hendrickx. I'm a full-time clinician in a place called Aalst in Belgium, where I work in a private practice teaching hospital, and I also hold secondary appointments at the University of Ghent and Louvain. I'm also an alumni assistant professor in Stanford, and I'm a member of the Committee of Technology of the Anesthesia Patient Safety Foundation. I also have my own low-flow annual anesthesia meeting, which I hold every year in Aalst in Belgium. Over the years, I've received support from basically every company involved with the delivery of inhaled anesthetic agents. I would like to thank GE Healthcare for both supporting and organizing this low-flow anesthesia project. I would also like to thank André de Wolf, my longtime friend and mentor, Professor Emeritus at the Feinberg School of Medicine in Northwestern University, Chicago. Let's start off by examining why we want to use or should be using low-flow anesthesia. Inhaled anesthetics remain the number one drugs used to provide or maintain general anesthesia worldwide. Now, all techniques carry a cost, financially, environmentally, and professionally. More and more institutions require us to document how we strive to minimize our environmental and financial footprint. Now, for inhaled anesthetics, there is a simple solution: low-flow anesthesia. The anesthesia workstation is inherently a recycling system. The circle breathing system allows rebreathing. Once the fresh gas flow drops below minute ventilation, you can actually say that you're using low-flow anesthesia because there will be rebreathing. In other words, exhaled gas will be recycled, except of course the CO2, which we will be scavenging using CO2 absorbents. And the lower the fresh gas flow is, the more benefit there will be. Modern workstations have small leaks and excellent gas analyzers, allowing us to safely use low-flow anesthesia. Compound A is a non-issue, and if you want, non-compound A producing CO2 absorbents are available. On the left graph here, you can see the effect of the fresh gas flow you're using on the sevoflurane use, expressed as milliliters of liquid sevoflurane. On the x-axis of this graph, you see the fresh gas flow that you're using, and on the left, the sevoflurane usage that you will be using, the sevoflurane usage when you're maintaining an anesthetic with sevoflurane in oxygen air with an ACES anesthesia workstation during 1 hour. And you can see that as you lower your fresh gas flow, sevoflurane usage will decrease proportionally, linearly proportionally with your fresh gas flow. So that is why low-flow anesthesia makes sense. Of course, when we are using low-flow anesthesia, CO2 will be rebreathed, and this will have to be scavenged, will be absorbed by CO2 absorbers. So the question arises, what is the effect of low-flow anesthesia upon CO2 absorbent use? And that is displayed on the right graph. On the x-axis, you can see fresh gas flow, and on the y-axis, you can see the fraction of a CO2 absorbent canister used per hour. The different colors represent different brands. But the main message of this graph is that as fresh gas flow is lowered, more CO2 absorbent is used. So the question then arises, how does low-flow anesthesia affect cost and environmental impact, expressed as CO2 emission equivalents, when we both take the decreasing sevoflurane use into account and increase in CO2 absorbent usage? Well, the effect is that both cost and environmental impact are reduced. The effect of CO2 absorbance is really, really small on the overall equation. Now, the next question is how to use low-flow anesthesia. The low-flow key code is FD, FI, FET. That is the difference between the delivered concentration, the oxygen concentration, or the vaporized dial-setting concentration for an agent, FD, the inspired concentration, the concentration the patient inspires, and the exhaled or end-tidal concentration, FET. Understanding the difference between these three is key. The difference between the inspired and end-tidal oxygen and anesthetic agent concentration is caused by uptake. The difference between this delivered concentration and the inspired concentration, 61% of oxygen and 2% sevoflurane, is caused by rebreathing. That is caused by low flow anesthesia. So let's delve a little bit deeper into this. If we lower the fish gas flow, there will be more rebreathing. Rebreathed gas with a lower concentration of the inhaled anesthetic agent and the oxygen will dilute the concentration of anesthetic agent and oxygen in the delivered or fresh gas. This will cause the inspired concentrations to decrease, resulting ultimately in an increase in the difference between the delivered and the inspired concentrations, which clinically means the concentration the clinician dials no longer matches the concentration the patient inhales. The result is that the concentration the clinician dials no longer matches the concentration the patient inhales. And the action to be taken by the clinician is to increase the oxygen concentration in the delivered gas and the vaporizer dial setting, and more so as fresh gas flow is lowered. Let's go to the operating room and do a little experiment here. We are going to compare the vaporizer dial adjustments, FD, needed with high fresh gas flows versus low fresh gas flows needed to maintain the same end expired agent concentration. On the x-axis here you see time, and the y-axis you see on the bottom the vaporizer dial setting course with high fresh gas flows, and on top the vaporizer dial setting with low fresh gas flows. If we use a high phase gas flow, bottom yellow, we can rapidly decrease the vaporizer dial setting because anesthetic agent washing is exceedingly fast. With lower phase gas flows, this will take longer, so we will be using a higher phase gas flow to overcome part of this delay, and we will keep it high for a longer period of time. You could, of course, use a high phase gas flow temporarily, but this would increase waste quite dramatically. During the next period here, you see that we are going to lower the fresh gas flow, and with the high fresh gas flow, there is barely any vaporizer dial settings to be done, while with the low fresh gas flow, you will see that you need not only higher vaporizer settings due to the breathing, but you also need more adjustments, especially in the beginning here. So why is this? That is because the uptake in the vessel reach group is rapidly decreasing, and this is more reflected in the vaporizer dial settings that you require with low flow anesthesia than it is with high flow anesthesia. During the maintenance phase, the vaporizer dial settings in the different patients will be more or less the same when you use a high phase gas flow. But if you use a lower phase gas flow, especially below 1 liter per minute, you will see that the vaporizer dial setting variability increases quite a bit. And that is because uptake differs up to 100% between different patients. And this is reflected more in the required vaporizer dial settings with low fresh gas flows. Finally, if you want to make a change in the end expired agent concentration, when this is easily done, for example, an increase, you change the vaporizer dial setting with the fresh gas flow, with a high fresh gas flow, and the end tidal will rapidly go towards the desired end tidal. With a low fresh gas flow, you will be inclined to use higher vaporizer dial settings to overcome the delay, so the change will be a bit slower, but you try to overcome that with high vaporizer dial settings. And there will also be more oscillations, which is typical for low flow anesthesia when you're using manual control. The other thing you have to do when you're using low fresh gas flows is increase the proportion of oxygen in the total fresh gas flow. You can see that in order to maintain 30% of oxygen in volunteers breathing from a circle breathing system, the proportion of oxygen in the total fresh gas flow has to be increased, especially between a total fresh gas flow lower than 2 liters per minute, and even more so with a fresh gas flow below 1 liter per minute. How does this work out in clinical practice? Low flow anesthesia really is easy. You start with a 1 liter per minute fresh gas flow, and the vaporizer is set at a maximum 8%. Then you lower the fresh gas flow more as washing proceeds to the lowest fresh gas flow you are comfortable with, and then further lower the fresh gas flow. Alternatively, you just maintain the 1 liter per minute fresh gas flow and start turning down the vapor and titrate it to the desired and expired agent concentration. And if you want, you can then decrease the fresh gas flow later. Adjust the vaporizer guided by the gas analyzer and apply the principles outlined in the previous slides. With regard to the oxygen delivery, you monitor the inspired oxygen concentration and then you adjust the oxygen and air ratio accordingly. Or if you use an electronic mixer, you just change the delivered oxygen concentration. The total fresh gas flow can be lowered until the bellows at end expiration just reach the top of the bellows housing. A few do's and don'ts. Do not use vapor prior to securing the airway. This will only serve to increase waste. If the anesthetic depth needs to be increased, administer more propofol. Do not use fresh gas flows higher than minute ventilation. This will only serve to increase waste. Do monitor your own progress. Use the displays of instant use on the workstations display and or reports of cumulative agent use at the end of the case. This way you will be able to track your own process. And finally, do stop agent delivery while maintaining low flows a while before the anticipated wound closure. This is called coasting, and you can maintain anesthesia a little while with this, and this will actually save a little more agent. Okay, a few further tricks to minimize waste. Use 0.7 MAC and titrate opioids and muscle relaxants accordingly. Exploit the synergy between opioids and inhaled anesthetics. Use automated target control delivery if available, because this will lead to a more consistent, ergonomic, and less distractive use of low-flow anesthesia. Consider agent choice. We all know that the environmental impact of cefluorine, desflurane, and nitrous oxide differ, but regardless of your choice, use low-fresh gas flows. Finally, practice. It will become part of your intuitive workflow. So to summarize, why use low-flow anesthesia? Well, for financial, environmental, and institutional reasons, and because it is easy and safe with modern anesthesia equipment, with the modern workstations. The key concepts you need to practice low-flow anesthesia is to understand the difference between delivered, inspired, and end-expired agent concentrations. You have to unlearn wasteful habits, and if you have an automated low-flow anesthesia machine available, use it. You can further minimize waste by using 0.7 MAC and titrate opioids and muscle relaxants accordingly. Consider your agent choice, and finally, overcome your own habits. Go for lower flow anesthesia. So again, I hope you find this information useful in your clinical practice. Just start to incorporate it into your daily clinical routine. And I want to end again by thanking GE Healthcare for organizing and supporting this project. Have fun practicing low-flow anesthesia and do your little bit for greening the operating room. Thank you.